Hello everyone, today we are finishing our deep dive into megaloblastic anemia, a profound disorder of cell division. We begin and end with a patient who perfectly embodies this critical clinical presentation. Okay, let's meet Mr. Jones, a 68-year-old man presenting with insidious fatigue, a smooth red tongue that is glossitis, and something perplexing. He's fumbling his keys. Examination reveals an impaired gait and difficulty distinguish between a tuning fork's vibration and simple pressure on his toes. His full blood count shows a hemoglobin of 88 grams per liter and a striking high MCV of 125 milliliters. Clinically, Mr. Jones is anemic, but the accompanying neurological signs, the gait disturbance and the loss of proprioception, transform this from simple hematological case into a neurohematological emergency. This presentation forces us to look beyond anemia and analyze the DNA blueprint failure at its core. So the underlying disease is a defect in DNA synthesis because of a lack of building block, that is thymidine triphosphate. The essential cofactors are B12 and folate. So the cell's nucleus stalls at the S phase of the cell. The cytoplasm, however, continues to mature. This mismatch results in the nucleocytoplasmic asynchrony and the characteristic megaloblast, a large immature cell. The vast majority of these defective cells are destroyed within the bone marrow by the process of intramedullary hemolysis. This explains the laboratory findings that mimic peripheral hemolysis, that is elevated LDH and elevated indirect bilirubin. And the key to Mr. Jones' case lies in the metabolism of B12. So folate recycling. B12 is a cofactor for methionine synthase. This is essential for recycling inactive folate into active form for the DNA synthesis. When B12 is deficient, methylmalonic acid accumulates. This accumulation is strongly implicated in damaging the myelin sheath, causing subacute combined degeneration of the spine. The exact neurological signs which we see in Mr. Jones are due to this very reason. Remember that folate deficiency does not cause these neurological signs. This is why you must never treat B12 deficiency with folate alone, as it allows irreversible neurological damage to continue unchecked while temporarily correcting the anemia. So it's always accompanied with B12. Our diagnostic pathway must be systematic. So initial screening, we confirm the macrocytosis as the MCV is more than 100 centiliters and look for hypersegmented neutrophils on the blood film. So this is basically a pathogenic sign or a pathognomonic sign. And Tier 2, for the Tier 2 confirmation, we test methylmalonic acid and homocysteine. Elevated MMA is virtually the diagnostic thing of B12 deficiency. And for Mr. Jones, given the neurological signs, we suspect vitamin B12 deficiency, mostly due to pernicious anemia. To guide the full information, I recommend reviewing the key lists in Oxford Handbook of Clinical Medicine, which we will do right now to ensure the complete differential diagnosis. So in the Oxford book, first they have mentioned about macrocytosis. So if the MCV is higher than 96 centiliters, they call it macrocytosis. And then further they are classifying macrocytosis into three: megaloblastic, non-megaloblastic, and the other one. So the other one is like the common one. So the megaloblastic, it's like it's the one we saw, the nucleus and the cytoplasm growth asynchrony. And non-megaloblastic is due to alcohol, excess reticulocytosis, or liver diseases, maybe hypothyroidism and pregnancy. And other diseases like myelodysplasia. So it's if macrocytosis accompanying myelodysplasia or myeloma or myeloproliferative disorders or aplastic anemia, it comes under this other category. So for tests, first we go for B12 and folate deficiency. So we would be able to see see hyposegmented neutrophils in B12 and folate deficiencies, and target cells if there's liver disease. And other tests will include LFT, TFT, serum B12, serum folate, etc. And red cell folate is also considered. It's a more reliable marker. And further, if we want to go for further tests, we go for bone marrow biopsy to see whether the patient has megaloblastic marrow, normoblastic marrow, abnormal erythropoiesis, or increased erythropoiesis. So folate, when we speak of it, it's found in green veggies, nuts, yeast, and liver. It's synthesized by gut bacteria and body stores it for 4 months. And folate, so the maternal folate deficiency is going to cause neural tube defects, and it's observed in the duodenum and proximal jejunum. So any defects over here or the ectomy processes over here may also lead to deficiency. So, and anti-epileptics, methotrexate, so these will also cause the deficiency. So we assess for the underlying cause, like whether it is poor diet, malabsorption, or whatever, and treat it with folic acid, like 5 mg per day PO for 4 months. And we are not giving it without B12 unless the person is found to have normal B12, which does not normally occurs. So we give it with B12. And yeah, so that's most of it. And then we have vitamin B12 deficiency. So it's common, occurring in up to 15% of the older people. B12 helps in synthesis of thymidine and hence the DNA. So in deficiency, RBC production is slow. Untreated, it will lead to megaloblastic anemia and irreversible CNS complications like we saw in Mr. Jones. Body stores of B12 are depleted for 4 years. So the causes, they are dietary malabsorption during digestion or intrinsic factor absence, and due to the terminal ileum issues or congenital metabolic issues. So like that. And features, we have general symptoms of anemia and lemon tinge skin due to the combination of pallor and mild jaundice. Glossitis is seen, angular cheiliosis is seen, and we have neuropsychiatric symptoms like irritability, depression, psychosis, and dementia. We have neurological symptoms too, like paresthesia, peripheral neuropathy, and subacute combined degeneration of spinal cord. So we could see the classical triad of extensor plantar, absent knee jerks, and absent ankle jerks. So yeah, basically that's it about B12 deficiency too. And Mr. Jones requires immediate intramuscular hydroxycobalamin 2 to halt the neurological progression. But to ensure we cover all the potential etiologies we saw in the that is why we went to the Oxford Handbook. And the patient's elevated MCV must trigger a systematic review of the differential. So here we remember CRISPs. So chronic alcoholism, reticulocytosis, intrinsic factor deficiency, sprues, in case of celiac disease or malabsorption, phenytoin or pregnancy, or subacute combined degeneration of the spinal cord. So that's it. Master the blueprint and the clinical causes, and you master megaloblastic anemia. There we go.